Outreach with AARP South Carolina. This virtual press conference is being recorded. AARP officially recognizes Black History Month and had already commissioned a health disparities research report with the South Carolina Aging Research Network, a collaborative partnership between Clemson University, the Medical University of South Carolina, and the University of South Carolina. The research report is focusing on African Americans 50 plus. We had a concern with health disparities and the high number of African Americans contracting and dying from COVID-19. AARP South Carolina and other parties representing vulnerable South Carolinians are deeply concerned with DHEC's board's recent decision to not prioritize older residents or vulnerable populations here in South Carolina for the vaccine distribution plan. We are pleased to have with us today Cheryl Dye, PhD, founding director of the Clemson University Institute for Aging, Professor Emeriti, Department of Public Health Sciences. Lucy Ingram, PhD, Associate Professor, Assistant Dean for Academic Affairs and Online Education, University of South Carolina, Arnold School of Public Health. Sue Veers, President and CEO, Carolina Health Centers Incorporated, and Chair of the Legislative Committee of the South Carolina Primary Healthcare Association. Kimberly Tiso, Executive Director, ABLE, South Carolina. Teresa Arnold, State Director, AARP, South Carolina. And Hank Povinelli, Volunteer, State Vice President, AARP, South Carolina. Let's get started, and I will call on Dr. Cheryl Dye from Clemson University with the South Carolina Aging Research Network. Cheryl.
Thank you, Joe. My graduate student, Kelsey Vincent, and I started to explore leading causes of morbidity and mortality this past fall semester. And the more we learned, the more we went in digging deeper and deeper into this issue of health disparities. We examined 14 leading causes of morbidity and mortality and 8 social determinants of health, such as income, education, housing, transportation. So of the 14 leading causes of morbidity and mortality, African Americans aged 50 and older in South Carolina suffered disparities in 12 of those 14. And then as we examined the social determinants of health, the 8 determinants we looked at, older South Carolinian African Americans suffered 7 of those health disparities in social determinants. So it was pretty striking to see how overwhelming the disparities were, both in morbidity and mortality causes and also its social determinants of health.
Great, thank you, Cheryl. My name is again Dr. Lucy Ingram, and I am at the Arnold School of Public Health at the University of South Carolina. So as Dr. Dye mentioned, there were a number of different health disparities that were noted. And so I'll just take a moment to report back on several of the recommendations that our group, including myself, Dr. Dye, Ms. Kelly Vincent, and also Dr. Heather Boger from the Medical University of South Carolina, and we supported this work. So the first recommendation is that there's greater public health and healthcare efforts that are needed to reduce the high rate of hypertension among non-Hispanic Blacks due to its impact on increased risk of heart disease, stroke, Alzheimer's disease and related dementias, as well as COVID-19. We also found that diabetes is also of significant concern, especially when it occurs as a comorbidity with hypertension and obesity. And therefore, Blacks suffering from this combination of chronic conditions should be prioritized to receive targeted, coordinated, and culturally appropriate healthcare and education. More efforts are also needed to improve use of dental care services by non-Hispanic Blacks, as poor oral health and tooth loss are also important risk factors for various conditions that include heart disease, as well as, again, Alzheimer's disease and related dementia, also known as ADRD. We also found that African Americans need concentrated outreach efforts to increase rates of colorectal cancer screening, and for men in particular, they need targeted efforts to increase prostate-specific antigen or PSA screening. Since non-Hispanic Blacks have higher rates of COVID-19 than we see amongst our white population, coordinated public health and healthcare efforts should focus on assuring they receive vaccinations as soon as possible. And lastly, social determinants of health, such as poor housing or homelessness, unsafe neighborhoods, and lack of transportation significantly contribute to health disparities of older African Americans. These determinants do require creative, coordinated solutions through a multi-agency collaboration. These recommendations, along with the emphasis that the coronavirus pandemic has placed on health and racial disparities, we're also planning for phase 2 of our research, which will be focused on qualitative research to further investigate these findings. And I'll turn it over now. Thanks.
Good morning. My name is Sue Veer, and as was said, I'm the president and CEO of Carolina Health Centers, which is a federally qualified health center in the Lakelands part of South Carolina. I'm also the chair of the legislative committee for the South Carolina Primary Healthcare Association, which is the membership organization for the state's 23 community health centers. The 23 health centers serve as the primary care medical home for over 400,000 South Carolinians, 91% of which live at or below the 200% of federal poverty level, and 63% of which are minorities. We have a well-founded concern about any vaccine allocation methodology that fails to prioritize those vulnerable populations, those populations that have both greater risk and reduced access to health care. I recently was doing a program on racial equity within the healthcare system, and I ran across, specific to COVID, a New York University study of 11,547 patients. And it supports the hypothesis that these populations have no innate vulnerability to the disease, but they have significantly increased risk due to the social determinants of health, a term that Dr. Dye started out with and that we've now heard a couple of times. Things like poverty, language, literacy, poor living conditions, poor working conditions, and living in areas with limited healthcare services and transportation. So we feel like those populations must be prioritized, not only for their benefit, but for us to get on the other side of this global pandemic. We also believe that the distribution methodology must correlate to demographic data, specifically age, relevant during any specific phase of the rollout, which is going to require adapting as we move through those phases, and it may require accommodating redistribution across districts. Finally, one of the things near and dear to my heart is that we need an unprecedented spirit of collaboration across the delivery system. Hospitals and health systems can't necessarily be considered the central point of vaccine distribution to the public. Many communities have no access to healthcare, to hospital systems, no transportation to hospital facilities, and there's well-documented hesitance among some of these vulnerable populations to use hospital facilities. So we, as the health center community, stand ready and able to stand in the gap here and help fight this battle.
Thank you, Sue. Good morning. My name is Kimberly Tiso, and I am the Executive Director of ABLE South Carolina. We are a nonpartisan nonprofit organization with a mission to create greater access and opportunities for independence through empowering individuals with disabilities and promoting community inclusion. Our organization is also run and operated by the majority of professionals with disabilities. While I'm the Executive Director of ABLE South Carolina, I'm also a person with a disability. I'm here today not for myself, but on behalf of the 26% of South Carolinians with disabilities, which includes people with significant medical conditions who are being forgotten and disregarded in our state's COVID-19 vaccine distribution. That's over 717,000 individuals in South Carolina whose lives are at stake. People with disabilities are considered vulnerable during public health emergency situations. During this pandemic, this issue has been extensively documented by hospitalizations, deaths, and during planning. People with disabilities are no strangers to institutional, environmental, and attitudinal barriers, but COVID-19 has brought new barriers, restricting further basic rights for people with disabilities, including the right to live, the right to access healthcare, and the right to independent living. Due to several factors, people with disabilities are at a greater risk of contracting COVID-19 or having conditions that would exacerbate the severity. We have seen many in the community die as a direct result of this pandemic. We are most concerned for people with significant healthcare needs, intellectual disabilities, developmental disabilities, and physical disabilities, and this is amplified within marginalized communities. Last week, the DHEC board voted to adopt a per capita model for vaccine distribution rather than the CDC's recommended social vulnerability index. With the per capita model, 95% of the state's weekly vaccine shipments would be doled out to counties based on their relative share of the state's populations within the remaining, with the remaining 5% set aside as a reserve. This is very dangerous. Prioritizing vaccine distributions per capita rather than the CDC's recommended social vulnerability index will result in the most vulnerable South Carolinians, including people with disabilities and healthcare needs, unable to properly protect themselves from COVID-19 despite being in the highest risk category. And yes, there are some people with disabilities living in nursing homes and other congregate settings who are listed in phase 1A. Some people might hear this and think, well, that means that the highest risk people have been already treated and taken care of. However, that has been a complete disregard for people with disabilities who have fought to stay out of these types of institutions and instead are receiving home and community-based services in the community of their choice. To be eligible for these services, someone must require nursing home level of care, yet within the current vaccine distribution, there have not been prioritized with nursing home residents. As a reminder, people with disabilities are all around you in South Carolina. It's 1 in 5 of us. We are your neighbors, parents, friends, teachers, colleagues, and associates in the community who have navigated this pandemic with an added level of fear, knowing they are at high risk for severe COVID and even death. These lives are critical and we must save them. Thank you so much for this opportunity.
Thank you, Kimberly. And thank you to everyone who's shown up today for our press conference. I wanted to let you know, I'm Teresa Arnold. I'm the state director for AARP. We have about 600,000 members in South Carolina that's 50 and older. And we have a motto in our organization that says we want to be a wise friend and a fierce defender. And right now we're weighing on the fierce defender side because we have data that shows that 95% of all deaths from COVID are from people 50 and older. And that's why we were so concerned with the DHEC board's decision last week to go on a population-only basis for vaccine distribution. Kimberly and I both serve on the South Carolina Vaccine Advisory Committee established by DHEC. And as far as I know, and Kimberly can correct me if I'm wrong, we were never presented with the opportunity to weigh in on a population-only type of distribution model. So we're very concerned about that. We are asking legislators to direct DHEC to look at vulnerable populations. Kimberly mentioned the Social Vulnerability Index. That's actually something that the CDC developed over the years that looks at the factors which makes communities more vulnerable during an emergency, such as a hurricane or a tornado. They know that those folks are going to need the type of care that are the resources disproportionately from other populations. And right now, what we have up here on the screen is a heat map. And the darker red areas are where the social vulnerability index is higher. You can also see those circles are infection rates, and the colored in circles within them are the death rates. And although it's not a perfect correlation, if you look at the heat map, you can see where we are having the most devastating effects of COVID for infection rates and death. So it actually, I mean, if I was a businessman, I'd look at that map and say, you know, we need to focus that vaccine where these red spots are. We need to make sure that we're going where the vaccine or the COVID infections are the worst, because that will help us get a handle on it. And it's truly not just a scientific type of decision. It's a moral and ethical decision. And that's why we called this press conference. We really would not have released our health disparities study quite so quickly because we just finalized it last week. But it fit so perfectly with what was going on that we felt like, man, we got to get this out to the public as quickly as possible. So I just want to thank all of you here, and I want to see if our volunteer Hank Povinelli, he's in one of the high-risk populations and also lives in a rural area. Is Hank on the line?
I am, yes.
Hey, Hank, if you wanted to just give a few words too.
Sure, thank you. And I'm kind of echoing what you all are saying, but in more of a statistical way, math. What I do, I'm kind of a math geek, among other things. And, you know, I guess the point that we're all trying to make is when you look at the population of our state, you and neglect the other issues, especially age and vulnerability, the scale gets skewed very, very severely. You know, you look at an area like Columbia, and, you know, Columbia has a high percentage of young people because of the college and the fact that it's the state capital where a lot of young people work. So it doesn't really equate with a county like my county, which is Lancaster, where it's a rural county and it's also an attractive county for retirees. So we have a disproportionate amount of seniors here in my county that are competing for the vaccines that are not distributed correctly. And then the other point I want to make is we're also a state that attracts and has many, many veterans. And the VA, the Veterans Administration, has their own allocation of vaccines that they allocate accordingly. And again, not to pick on Columbia, but you look at Columbia as an example. Between Fort Jackson and the largest VA hospital in the state, it gets a tremendous amount of vaccines that are shared with veterans that are on their TRICARE Medicare application or healthcare. Again, those numbers are not added in to the allocation percentages when the state is trying to calculate how to distribute vaccines. So my peers in Columbia appear not to be having much of a problem getting a vaccine, but it took me, I tried to get a vaccine appointment the first day that the website opened up, and my vaccine appointment isn't until the middle of February, which is 6 weeks from the time I tried it. And I'm one of those guys that checks all the boxes. I'm 73. I am a veteran, not on TRICARE, and I'm a cancer patient. So, you know, I should be the head of the line, but there's no way that I can get that vaccine, and I'm lucky to get the one I got. So I guess my point is to reiterate what you all are saying and say it in just the math. Just do the math. It's not that hard. Thank you.
Thank you for sharing your personal story, for being the volunteer that you are. And thank you to all of our speakers for sharing your information with us this morning. I know that we have several different media outlets, so we'll move into our question and answer section at this time and ask if the media has any questions.
Good morning, everybody. This is Nick with WPDE in Myrtle Beach, South Carolina, obviously South Carolina. I don't know how many of you listened in on the DHEC board meeting where that decision was made. So I'll ask a question based off of that, and hopefully one of you might have a response. During that meeting, for those of you that may not have been listening in during that meeting, the DHEC's decision was made solely off of one thing, and that was after hearing that the population-only model got shots into arms faster. We are following up with DHEC to find out how much faster, because they did not answer that question during that meeting. But in the meantime, what would you say to that in terms of ending the pandemic? That was what they were going off of. How would you respond to that decision and that factor?
This is Teresa, and I also asked Sue. Actually, I was going to ask Sue if she would be willing to weigh in on that.
Sure. Let me give an example from my health center alone. We got our first allocation of the Moderna vaccine approximately 2 weeks ago, and we are a relatively large health center in the state. We have 10 medical sites across that serve 7 counties. And because of we got a total of 2,400 doses. And because of being in the phase we're in, we did an EHR search for our patients only, and had 2,576 patients that were 70 and above. And so we began calling those patients. Yet last week in a gymnasium, we vaccinated 540 patients. It was quite an undertaking, but the idea the only way we're going to get shots in arms when you're dealing with a phased distribution strategy is to be able to tailor your allocation to, number one, the people in that phase, and then number two, the people that have the greatest risk and the least access otherwise. So for me, that's the point. We have a limited supply. Have a high number of patients in certain areas, lower number of patients in other areas. For example, one of my fellow health centers, I talked with her, and they were opening their vaccination up to the general public quickly instead of just their patients, because they have very few people 70 and over. So they had to be sensitive to the fact that they couldn't necessarily bring their patients in. They needed to go out to the general public. So it's a supply, a demand, and then what are the limitations set based on the phases? And then finally, who is at greatest risk? And that has to be an equal priority.
And let me just state too, that there is a bill going through the House. Well, it passed the House and it's in the Senate, 3707, which provides resources to DHEC for the vaccine administration. And it does address factors such as poverty. It's not strong enough, I don't think, to make sure that DHEC is doing what they need to do. And they passed this bill at the same time DHEC was voting on a population only model. So I feel like it doesn't have to be either or. We can still do a better job, yet target those who are most vulnerable.
Okay, thank you. Are there other questions from the media?
Hi, yes, I have a question. My name is Sydney Heiberger. I'm a reporter in Aiken, North Augusta area. My question is, what do you feel the likelihood is that DHEC will change their decision? I mean, last week it seemed that their vote was final. So obviously, we're having this meeting today. Are we hoping that, something will change? What's the likelihood of that happening?
Thank you. Teresa, do you want to take that question?
Yeah, so my understanding is they're supposed to come back in 2 weeks to revisit the decision. But in addition, if the Senate passes this bill and the House concurs, it will be the law. And DHEC will be out of compliance with the law if they don't consider vulnerable populations.
Thank you, Teresa. Do we have other questions from the media?
can ask another one.
Okay.
How can you give the state a grade? And I'd probably ask for two different grades, in your opinion. We had the initial rollout, which I don't think anyone can argue wasn't bumpy. And then we've had the last maybe week or two where things have picked up and vaccine doses are being utilized more. How would you grade the state, both in that initial rollout and then just in the last week or two when things seem to have been smoother?
Thank you, Nick, for that question. I'll call on Kimberly Tissot. You're a member of the Vaccine Advisory Council and you've worked here in the state. Can you respond to Nick's question, please?
So if we were to give a grade level, I would give the state an F, and especially within the population that I represent, people with disabilities, we have completely been disregarded as and we're looked at like our lives do not matter with saving. And I can't tell you how disappointed our community is and how scared our community is with the state's actions.
Thank you, Kimberly.
And I'd like to say that for many of our members, 70 and older, it was difficult to get an appointment, but they all, pretty much everyone I've talked to said that once they got the appointment or once they got to the vaccine location, everything went very smoothly. And they were so grateful to have the opportunity to get the vaccine. So I think it's more on the front end. It's more, we're concerned with how do people access it. And the other population that we at AARP are really concerned about are those without internet access. We've talked to several people who say, I can't get on the internet, so there's no way for me to make an appointment. And when I call the number, it just rings and rings and rings. Now, I'm really happy that DHEC has set up a new toll-free number. So we're hoping that from that perspective, things are going to start going more smoothly.
Teresa, would you mind if I add something to that?
Sure.
I would have to echo the low grade in general, but I have to say I want to give an A for effort for the boots on the ground people, because oh my gosh, I have never seen my team mobilize any more quickly with little direction. I mean, literally little direction and one barrier after another, internet being one of them. Even as an approved vaccine point, we could not get registered in the vaccine administration management system for days and days and days. But to your point, Teresa, about internet and broadband, even if they have internet and there's not adequate broadband in the area, it's a problem. And what we've done at last week's vaccination event, where I said we did 540 some people in a gymnasium, we're not requiring people to go through the internet to make their appointments. We're doing that on the back end. We're doing all of, we're entering their data into the vaccine administration system. I have staff lined up doing that, because that's a barrier. And the goal is to get shots in arms, not to make people jump through all these hoops that they don't understand.
Thank you. Thank you, Sue. Do we have other questions from the media?
Can I follow up with Sue? I don't want to steal the whole limelight here. Sue, you mentioned the system that's being used, and I've heard many things about that system from many different people. How much of the responsibility and the effort that's been lacking so far rests with the state, and how much of the responsibility rests with the federal government?
Wow, that's a huge question. I would say it's a point of where's the root cause, and I would say the root cause goes back several months to the fact that we didn't do adequate planning and well-informed planning in advance. We didn't anticipate what the system was going to need to be. And so I work with health centers all across the country. I collaborate with them, and every state is having a different level of problems. I think I would say the root is lack of good planning at the federal level. And therefore the states were unprepared to take the ball and run with it. It's basically, here's a vaccine, figure out what to do with it. So, that I think Teresa, others may have more knowledge. I haven't been really participating at the state level in the policy formation. I think some of you have.
Thank you. Does anyone want to add?
I do want to remind people that the reason that we call the press conference today, in addition to DHEC board's vote last week, is because we have new data that we can share with all of the reporters on health disparities, which again highlights why we need to focus the vaccine on the front end for the ones who are most vulnerable. Not that we're not all going to get the vaccine. We will, as long as you want it. I think everyone is going to get it. It's just we need to figure out who gets it first. And Joe Myers is our communications director, and he'll have that information to provide to all the reporters on this call. I don't know if he can provide it by a link or if he's going to email it to you.
Okay. Do we have any other questions from the media?
Yeah, hi. This is Matt Koufax from Fox Carolina here in Greenville. Can you all hear me all right?
Yes, we can.
Okay, perfect. I wanted to focus just sort of more on looking towards the future. I know that, we are, sort of unhappy with the response so far from the state. I know that there is that bill in the Senate that could give DHEC assistance to target vulnerable populations, and that we're hoping that, when they meet again in 2 weeks to potentially revisit the decision, that they will revamp or rework their approach. What is your message to the communities that you represent in the meantime, as we, as you continue to fight for, what you view as your fair share?
Okay, thank you for that question, Matt. Teresa, would you like to respond?
Well, first, I would like to say that obviously we have to all wear our mask, except in a virtual press conference. But masking and physically distancing is still going to be hugely important for the next several months. So that's the first thing. And then the second thing is that I think it's going to get smoother. We've got more vaccines coming. I think this is going to be a process that once it really starts moving, it's going to do a lot better. I do credit the staff at DHEC. They are working 7 days a week, many, many hours a day. And I feel like if we can just make sure they have enough resources to help deliver the vaccine, I think we can do better.
And if I can speak from the point of a provider, an organization that is in boots on the ground giving vaccines, I think when we get to that point where supply allows us to open up all those phases, it is going to, we are already, our vaccine, we've had a COVID-19 response team meeting twice a week since March of last year. And now we have a vaccine deployment subcommittee of that. And they're already looking months out to when there is no limitation based on the phasing and when there is no limitation based on the supply. And that, I think then what we will be dealing with is education and removing as much of the vaccine hesitancy as we can.
Okay. Thank you, Sue. I'll ask again if there are questions from the media.
I did want to follow up on what Sue just said. She had talked about how you all are already envisioning a scenario where, supply and other things aren't obstacles. Does that mean that, you're sort of gearing up for when there is more vaccine available to sort of launch your own initiatives and vaccination campaigns and things like that? I mean, are we getting a glimpse of, future plans right now?
The future is very, it's in formation. It's very fluid right now. I think I had a meeting before this press conference with my chief operating officer, who is heading up our vaccine deployment strategy. And yes, I mean, we're seeing this particular phase was in some ways maybe the easiest because we had a very defined population of over 70 and then the other categories. When it opens up a little bit more, it's going to get a little bit more difficult because it gets bigger. And the question is, when it gets bigger, do we have the supply to address that? But I think it behooves us to be envisioning that scenario 6, 7, 8 months out, 12 months out, where this becomes a part of our public health strategy and our preventive care strategy within the health centers.
Thank you, Sue. All right, any other questions from the media? All right, hearing none, then we will thank each of you for joining us this morning for this press conference, each of our speakers and the media for your presence with us. And we ask you to continue to follow the progress on social media with our AARP South Carolina via Twitter, Facebook, and our website. And that concludes this press conference. Thank you. Have a great day.